Hello everyone, this lesson is about infective endocarditis. My content is definition, classification, epidemiology, pathogenesis, etiology agent, clinical manifestation, diagnosis, treatment, complication, and the prevention of infective endocarditis. Infective endocarditis is an infection of the endocardial surface of the heart, primarily of one or more heart valves and the mural endocardium and also the septal defect. And infective endocarditis can be classified into four groups: native valve infective endocarditis, prosthetic valve infective endocarditis, and intravenous drug abuse infective endocarditis, and also nosocomial infective endocarditis. When we see further classification, we can classify infective endocarditis into acute and subacute. Acute infective endocarditis affects mainly normal heart valves, and this is mainly rapidly destructive, and there is a metastatic focus in other organs, and commonly it is caused by Staph aureus, and if not treated, it is fatal within 6 weeks mostly. Whereas the subacute type is it often affects damaged heart valves due to different reasons, and it is most of the time it's indolent in nature, and if not treated, it is usually fatal by 1 year. When we say about pathophysiology, patients with a congenital heart lesions where there is a turbulent blood flow because of hole or stenotic orifice, especially if there is a high pressure gradient across the defect, are most susceptible to endocarditis. This turbulent flow traumatizes the vascular endothelium, creating a substrate for deposition of fibrin and the platelets, leading to the formation of a non-bacterial thrombotic embolus that is thought to be the initiating lesion for infective endarteritis. Biofilm forms on the surface of the implanted mechanical devices such as a valve, catheter, or pacemaker wires, which also serve as an adhesive substrate for infection. The development of a transient bacteremia then colonizes this non-bacterial thrombotic embolus or biofilm, leading to proliferation of bacteria within the lesion. Bacterial surface proteins such as Femi-antigen inviridian streptococcus and others, after which bacteria can rapidly proliferate within the vegetation, giving the heavy colonization of mucosal surface such as the oropharynx, the gastrointestinal, vaginal, or urinary tracts by potentially pathogenic bacteria. The surface are thought to be the origin of this transient bacteremia. Turbulent blood flow due to hollow or stenotic orifice, especially from high pressure gradient across a defect, are most susceptible to endocarditis. When we say about the location of the vegetation infecting endocarditis, vegetations tend to occur when blood travels from an area of high pressure through a narrow orifice into an area of lower pressure. Vegetation in patients with pre-existing valvular lesions are usually located on the atrial surface of incompetent atrioventricular valves or the ventricular surface of incompetent semilunar valves, because vegetation occurs on the low pressure side. Patients with VSD tend to develop vegetation on the orifice of the defect or on the right ventricular side of the opening, and secondarily on the tricuspid and the pulmonic valves. Regarding risk factors, there are different risk factors for infective endocarditis: intravenous drug abusers, artificial heart valves and the pacemakers, acquired heart defects such as rheumatic arthritis and the previous infective endocarditis, congenital heart defects with lesion where there is a turbulent blood flow because of a hole or stenotic orifice such as VSD, PDA, coarctation of aorta, tetralogy of Fallot, mitral valve prolapse with regurgitation are all risk factors for infective endocarditis. And also intravascular catheters are risk factors. Regarding etiology, the most common bacteria that cause infective endocarditis includes Viridians group Streptococcus and Staph aureus, and also group D Streptococcus. Whereas other bacteria that can cause endocarditis, which are not common, include Pseudomonas and the Hasek group. And also fungus can sometimes cause infective endocarditis, especially in those who have open heart surgery. Overall, staphylococcal endocarditis is more common in a patient with no underlying heart disease. Viridians group streptococcal infection is more common after dental procedures. Group D enterococcus are seen more often after lower bowel or genitourinary manipulations. And Pseudomonas aeruginosa or Serratia marcescens is seen more frequently in IV drug abusers, and fungal organisms are encountered after open heart surgery. And coagulus negative staph aureus are common in the presence of indwelling central venous catheter. Regarding symptoms, there is acute and subacute infective endocarditis, and even though symptom overlaps, acute infective endocarditis causes rapid onset of high-grade fever and chills, shortness of breath, arthralgia, myalgia, abdominal pain, pleuritic chest pain, back pain, and the like. Whereas the subacute infective endocarditis causes low-grade fever, anorexia, weight loss, fatigue, abdominal pain, nausea, and vomiting. And the onset of symptoms is usually 2 weeks or less from the initiating bacteremia. Patients have fever most of the time, heart murmur, which is new or changing in type, non-specific signs such as petechial rash, subungual or splinter hemorrhages, clubbing, splenomegaly, and other neurologic changes. And also more specific signs such as Osler's nodules, genuine lesion, and rose spots come there. When we see splinter hemorrhage, this is more, it is a non-specific and it is a non-blanching linear reddish brown lesion found under the nail fold, and usually do not extend to the entire length of the nail. So as you see on the image, it is a linear reddish brown lesion found under the nail bed. Whereas the genuine lesion is it is an erythematous blanching macules, and most of the time it's non-painful and more specific for infective endocarditis, and its location on is mainly on palms and the soles. And Osler's nodules is more specific for infective endocarditis, and it's painful, and erythematous nodules located on palp of fingers and the toes, more common in subacute infective endocarditis than acute. The essential blood test that we should have to do is blood culture. Blood culture is very important for the diagnosis of infective endocarditis, and the minimum of 3 blood culture should be sent, and the 3 separate venipuncture sites should be secured, and we should have to obtain 10 to 20 ml of blood in adults and 1 to 5 ml in children. And we say positive blood culture if there is a typical organism present in at least 2 separate samples, or if there is a persistently positive blood culture in atypical organisms in 2 positive blood culture obtained at least 12 hours apart, and 3 or more positive blood cultures in which the first and the last sample were collected at least 1 hour apart. Additional lab tests that is needed can be CBC, ESR, and CRP, which is acute inflammatory response, and complement levels, renal function test, urine analysis, and baseline chemistry and the coagulation test can be done. Regarding imaging, chest X-ray can tell us for the presence for multiple focal infiltrates and the calcification of the heart valve if seen. And on ECG, look for evidence of ischemia, conduction delay, and arrhythmia. And the other important imaging that should be done is echocardiography. And echocardiography detects vegetation and assess the range of vascular damage and the hemodynamic abnormality in endocarditis. To diagnose infective endocarditis, we need a modified Duke criteria. We say definite infective endocarditis, possible infective endocarditis, and rejected infective endocarditis. To see definitive infective endocarditis, we need either a pathological criteria or a clinical criteria. On pathological criteria, presence of microorganisms via culture or histology in valvular vegetation, embolized vegetation, or intracardiac abscess, and also identifying the etiology from a pathologic lesion such as vegetation or intracardiac abscess present or confirmed by histologic showing active endocarditis can confirm the diagnosis. And also we can say definitive infective endocarditis if there is 2 major criteria, 1 major and 3 minor criteria, or 5 minor criteria. We say possible infective endocarditis if 1 major criteria and 1 minor criteria or 3 minor criteria is there. And we say rejected infective endocarditis if there is a film alternative diagnosis for the manifestation of endocarditis, if there is a sustained resolution of a manifestation of endocarditis with antibiotic therapy for 4 days or less, and if no pathological evidence of infective endocarditis as surgery or autopsy after antibiotic therapy for 4 days or less. Major criteria include positive blood culture. In this case, we say positive blood culture if there is typical microorganisms for infective endocarditis from 2 separate blood culture as we have said above, and blade culture greater than or equal to 2 during 12 hours apart, or 3 or measure of 4 or more separate blade culture with first and last during at least 1 hour apart for microorganisms that are not the most common etiology, and also presence of single positive blade culture for Coxiella burneti can give us a positive blade culture that fits a major criteria. And evidence of endocardial involvement is seen on echocardiography. We say positive echocardiography there is oscillating intracardiac mass on valve or supporting structure or in the path of regurgitant jets or on implanted material in the absence of alternative anatomical explanation, or presence of abscess, new partial dehiscence of prosthetic valve and new valvular regurgitation can all meet positive echocardiography, and this is the major criteria. Minor criteria include predisposing factors, presence of fever, vascular phenomena, immunological phenomena, microbiological evidence, and in addition, the presence of newly diagnosed clubbing, splenomegaly, splinter hemorrhage, or PTK, high ESR and CRP, and also the presence of central and feeding lines, peripheral lines, and the microscopic hematuria can all fulfill the minor criteria. Regarding the treatment of infective endocarditis, it is mainly medical. Parenteral antibiotics is required. This parenteral antibiotics should have to achieve high serum concentration to penetrate vegetation, and also should have to give for a prolonged treatment to kill dormant bacteria, which is clustered in a vegetation. And also surgical treatment might be needed if there is intracardiac complications such as intracardiac abscess, and also interactive failure to sterilize the blade despite adequate antibiotic therapy, and also increasing the size of the vegetation while receiving therapy. Regarding prevention of infective endocarditis, the most important factor is to maximize oral health and reduce the oral microflora, and we should have to minimize oral tissue trauma, periodontal and plaque control, and also antimicrobial mouth rinses, and also proper American Heart Association prophylactic regimen only when indicated. Cardiac conditions associated with the highest risk of adverse outcomes from endocarditis, for which prophylaxis with a dental procedure is recommended, currently include prosthetic cardiac valve, previous infective endocarditis, congenital arteries, especially unrepaired cyanotic CHD, completely repaired CHD with prosthetic material or device, either by surgery or catheter during the first 6 months after procedure, and also repaired CHD with a residual defect at the site or adjacent to the site, and also cardiac transplantation recipients who develop cardiac valvulopathy. Those are the antibiotics that we should have to give during a dental procedure for those who have indications. It includes mainly amoxicillin, and if they are not taking orally, ampicillin or ceftriaxone can be given, and if they are allergic to penicillin or ampicillin, cephalexin, clindamycin, or azithromycin, neclarelithromycin can be given. Regarding complications, complications can be embolic, local spread of infection, metastatic spread of infection, or formation of immune complex glomerulonephritis, and the arthritis can act. When we see embolic complications, it occurs in up to 40% of patients with infective endocarditis. And the predictors of embolization include big size of the vegetation, mainly greater than 1 centimeter, left-sided vegetation, and the fungal etiology, and also Staphylococcus and the strep bovis are at high risk for embolization. And also the incidence decreased significantly after initiating of effective antibiotics. When we see another embolic complications is stroke, myocardial infarction, mainly fragments of valvular vegetation or vegetation-induced stenosis of coronary ostia, and ischemic limbs, and hypoxia from pulmonary embolism can happen. And also abdominal pain from splenic or renal infarction can occur. Local spread of infection include heart failure that cause extensive valvular damage, paravalvular abscess, and also pericarditis and fistulas intracardiac connections. Regarding metastatic spread of infection, metastatic abscess to kidney, spleen, brain, and the soft tissue, and meningitis and encephalitis, and also vertebral stomatitis can occur, including septic arthritis. When we see mortality rate of a patient having infective endocarditis, it is 100% fatal if not treated. And with appropriate antibiotic treatment, fatality rate is for native valve endocarditis, it is around 10% for streptococcus to around 83% for fungus and gram-negative etiologies. And the prosthetic valve have 30 to 53% mortality rate. Thank you for your attention, and don't forget to subscribe this channel.